The latissimus dorsi attaches from the spinous processes of T7 to L5, posterior sacrum and iliac crest, and then runs superiorly and distally to attach up into the medial lip of the bicipital groove of the humerus. To engage and palpate this muscle, we place the client's arm on our shoulder and ask the client to press down toward extension and adduction of the arm at the shoulder joint against the resistance of our shoulder. We can easily see the contraction of the latissimus dorsi in the scapular region here. As the client alternately contracts and relaxes the muscle, we can strum across it and palpate into it proximally and inferiorly onto the trunk. From there, we can then go back to the scapular region and palpate the muscle superiorly and distally into the axilla. The latissimus dorsi can easily be palpated all the way to its humeral attachment at the medial lip of the bicipital groove of the humerus. The erector spinae group is a large group of musculature that sits to the side of the spine. It is made up of three subgroups: the spinalis, the longissimus, and the iliocostalis. The iliocostalis is the most lateral, attaching from ilium to ribs. The longissimus is the longest, and the spinalis attaches from spinous processes to spinous processes. So this muscle group goes from the pelvis up to the spine, rib cage, and all the way up to the mastoid process of the temporal bone of the head. To palpate this musculature, we ask the client to extend his trunk at the spinal joints, and we can see the muscle group engage. We strum across it perpendicularly. It is easiest to find this muscle group in the lumbar region and the thoracic region. As the client extends his trunk at the spinal joints, we can feel for the width of the muscle, and we can find its lateral border here. As the muscle group goes superiorly, it starts to widen out laterally. Again, the erector spinae group is easiest to palpate in the lumbar and thoracic regions. It is more challenging to palpate in the upper thoracic region and the neck. The transversospinalis group, in addition to the erector spinae group, is another large group of musculature located lateral to the spine. It is made up of three subgroups: the semispinalis, the multifidus, and the rotatories, the major difference being the angulation of the fibers. The semispinalis is oriented this way, the multifidus this way, and the rotatories like this. The semispinalis is the most superficial, the multifidus is deeper, and the rotatories are deepest, and these muscles are located in what is called the laminar groove of the spine. The laminar groove is located between the spinous processes and the transverse processes. So we place our palpating fingers over the laminar groove, and we ask the client to extend up and to rotate to the opposite side, and we feel for the contraction of the transversospinalis musculature. The contralateral rotation is specifically important because it will help to both engage the transversospinalis as well as to inhibit and relax the more superficial erector spinae musculature. We can then continue palpating the transversospinalis superiorly in the trunk. To palpate the semispinalis cervicis and capitis in the neck region, it is located midline directly deep to the trapezius. So we need to inhibit the trapezius, and we do this by placing the client's hand in the small of her back. This extends and adducts the arm at the shoulder joint, which downwardly rotates the scapula at the scapulocostal joint, and this inhibits the upper trapezius because it is an upward rotator of the scapula. We now ask the client to extend her head and neck, and we can feel that the upper trapezius is sufficiently relaxed that we can feel the contraction of the semispinalis deep to it. The quadratus lumborum, or QL, is located in the low back, hence lumborum, and it is four-sided, hence quadratus. Much of it is deep to the erector spinae group, so to palpate the quadratus lumborum, we need to first locate the erector spinae group and drop off it laterally. To engage the erector spinae group, we ask the client to extend his trunk at the spinal joints. This engages the erector spinae group and we can palpate it until we find its lateral border. The client can now relax, and now that the lateral border of the erector spinae group is found, we drop just off it laterally between the iliac crest and the 12th rib, and we press in medially deep to the erector spinae group. To have the client contract, to confirm that we are on the quadratus lumborum, we ask him to elevate his pelvis at the lumbosacral joint by moving his pelvis superiorly on the right side. We see that action being done now. We can then press down against the iliac crest for the lower fibers. We can press upward against the 12th rib for the more superior fibers, and we can press straight in medially for the middle fibers. Because this muscle is fairly deep, it can be more effective for our palpation and more comfortable for the client if we go in stages. We ask the client to take in a breath, and when he exhales and relaxes, we sink in a bit. We then ask the client to take in another breath, and when he exhales and relaxes again, we sink in more. And then we have the client take in one more breath, and when he exhales and relaxes this time, we can sink in all the rest of the way to access the fibers of the quadratus lumborum. The interspinales, as their name implies, are located between spinous processes in the lumbar region and the cervical region. To palpate these muscles, we feel for the hard spinous processes and also the soft interspinous spaces located between them. We then place our palpating fingers in the interspinous spaces and ask our client to slightly flex forward, which opens up these spaces. We are now palpating the interspinales. To engage and confirm we're on them, we ask the client to extend back, and we can feel for the contraction of these muscles. The external and internal intercostal muscles are located, as their names imply, between ribs. To best palpate these muscles, we have the client side-lying, where there's less musculature overlying the rib cage, and we find the hard texture of a rib, and then the soft intercostal interspace, and then the next adjacent rib. We drop back into the soft intercostal space, and we are palpating the intercostal muscles. We can palpate them posteriorly, and we can palpate them anteriorly. Once we have palpated the intercostal muscles at that level, we can then palpate at other intercostal levels to palpate more of the intercostal muscles of the rib cage, palpating them posteriorly as well as anteriorly as far as possible. The rectus abdominis is one of the 4 anterior abdominal wall muscles and is located in the midline in this region. It attaches to the costal cartilages of ribs 5 through 7 and the xiphoid process here, and it comes down inferiorly to attach into the pubic bone located here. This muscle is a flexor of the trunk at the spinal joints, so we ask the client to curl up, and with the muscle engaged, we can palpate perpendicular to it until we find the lateral border. Here is the width of the muscle, and we can see that it narrows as it goes down the trunk to its inferior attachment on the pubic bone. This muscle is also well known for having characteristic boxes which are often visible in well-developed individuals such as this client here. The external abdominal oblique attaches into the abdominal aponeurosis, the inguinal ligament, the anterior iliac crest, and from there it attaches to the lower 8 ribs, and its fiber direction runs this way. This muscle is an anterolateral abdominal wall muscle, so to palpate it we first need to find the rectus abdominis, so we ask the client to curl his trunk up a bit, and we can feel for the lateral border of the rectus abdominis here. Once this border is found, we drop just off it laterally, and then we ask the client to curl the trunk up into flexion and rotate to the opposite side, and we can strum perpendicular to the muscle fibers of the external abdominal oblique. On this client, we can even see some of the slips of the muscle. From here, we continue palpating the rest of the muscle to the posterior side of the body. The internal abdominal oblique is another anterolateral abdominal wall muscle. It attaches from the inguinal ligament, the iliac crest, and the thoracolumbar fascia in back, and from there it travels in this direction to the lower 3 ribs and the abdominal aponeurosis. Whereas the external abdominal oblique is oriented this way, the internal abdominal oblique is oriented perpendicular to it this way. To palpate the internal abdominal oblique, we need to find the lateral border of the rectus abdominis, so we ask the client to curl up the trunk into flexion, and we locate the lateral border. We then drop just lateral off of the lateral border of the rectus abdominis, between the iliac crest and the rib cage. We ask the client to flex up and rotate ipsilaterally to the same side, and we palpate perpendicularly across the internal abdominal oblique this way. Having the client rotate to the right both engages the internal abdominal oblique and also helps to inhibit and relax the external abdominal oblique, so we can better palpate and discern the deeper internal abdominal oblique. The diaphragm, as its name implies, is a partition between the thoracic cavity and the abdominopelvic cavity. It attaches to the inner surfaces of the lower 6 ribs and also to the upper 3 lumbar vertebrae. To access the diaphragm, we need to go on the underside of the client's rib cage. We find the inferior margin of the rib cage. We curl our fingers around to the inner surface. Ask the client to take in a breath, and as the client exhales, we palpate against the inner rib cage for the diaphragm. We can repeat this procedure medially, moving toward the rib cage attachment to the sternum, and we can repeat this procedure laterally. Even though this is a bit of a deep palpation, if we palpate gently but firmly and sink in slowly, it is usually perfectly comfortable for the client. We ask the client to take in a breath, and as the client breathes out, we press against the attachments. We access as far laterally and posteriorly along the inner surface of the rib cage as we can. So the diaphragm can be palpated in this entire region of the rib cage. The iliopsoas is made up of two parts. There is the psoas major portion that comes from the spine, runs inferiorly to cross the hip joint, and attaches into the lesser trochanter of the femur here. And the iliacus portion, which attaches to the internal surface of the ilium and crosses the hip joint to join the psoas major on the lesser trochanter. To palpate the belly of the psoas major, we find the ASIS and belly button and then go halfway in between. Or we can palpate for the lateral border of the rectus abdominis, which is right here. Once we find the lateral border, drop off it just a bit laterally, and then we can use this location to palpate the belly of the psoas major. We ask the client to slightly flex the trunk forward, which relaxes the anterior abdominal wall, and we ask the client to take in a breath, and as she lets the breath out, we sink in posteromedially toward the spine. We ask her to take another breath in, and as she lets it out again, we sink in further. We are now against the belly of the psoas major here. To engage the psoas major, we ask the client to lift her foot off the floor, flexing the thigh at the hip joint, and we can then feel the contraction of the psoas major. It is important with this palpation to be firm, but to be gentle and sink in slowly. We palpate as much of the psoas major as we can in this manner.